you for joining us. We are going to be doing some case presentations tonight for linking APPs with ILD experts like Kelsey, my teammate here. And so we want to first thank BI for sponsoring this program. We had our in-person event last week that went very well. And now tonight we're going to be presenting these cases and kind of walking you through two really interesting cases, I think, that kind of really highlight what we talked about last week as far as fitting the picture of screening and treating ILD and people who are high risk of ILD. So it's kind of good to put a face with the disease, kind of a whole picture overall. So. All right, so we're going to, like I said, a case-based journey through ILD and rheumatic disease. And case number one is called I Thought RA Was About Joints, rheumatoid arthritis about joints. So we're going to recognize and manage RA-associated interstitial lung disease. So we are going to start with our friend here. His name is, according to this slide, is LBJ. I don't know what kind of name that is. The next one is another name. I kind of was like, well, okay, sounds good to me. But so can we call him like Louis or something? Because I think that's way more interesting than
Louis. Hi, Louis.
Louis. Yeah, I like Louis. Okay, so Louis is a 67-year-old male, and he has a known history of seropositive RA, and he was diagnosed 4 years ago. And when on diagnosis, his rheumatoid factor was greater than 300. So for
I think it froze up a little bit, Amanda. You want to repeat what you said?
Yeah, sorry. Let me just
Or
see
mine.
about. Oh, am I okay? Am I frozen?
You're totally fine now. So you just said last I heard was he presented with.
Oh, okay. So, did you hear that when he presented with RA, he had a rheumatoid factor of over 300. His anti-CCP antibody was over 60. So these are considered very high antibodies for rheumatoid arthritis. And he was started on methotrexate. And usually with any RA patient, insurance makes us give about a 3-month trial of methotrexate before allowing us to go on to another biologic. So we're going to say he had a 3-month trial, could have been longer, whatever, but and he was still active. So we added adalimumab, and that was added about 2 years ago. Well, I guess it says 2 years ago, so he had it for 2 years anyway. And so we added adalimumab given his ongoing disease. So he's going to come into primary. And he's going to be telling his primary care doctor, hey, listen, I'm really, really tired. I'm really, really short of breath, even with just like little movements. So maybe getting up to walk to the bathroom or getting up from the couch to the refrigerator to get your bowl of ice cream at night for your lovely dessert snack. But with mild exertion, he's short of breath. And this has been going on for about 6 months. And so the question is what features in this patient's history suggests the higher risk of ILD? And I always like to do the rhetorical questions. Or Kelsey, do you want to answer?
Well, I want to test my knowledge a little bit from last week, but obviously the history of rheumatoid arthritis puts him at risk for interstitial lung disease. Those two diseases go hand in hand. And did you say something about higher serological markers at diagnosis put them at risk?
Correct. Yes, higher serological markers. So the fact that his RF was over 300, CCP antibody was over 60. Those are very high markers, so that puts him at risk. Yep. Mm-hmm. Very good. Very good. Anything else that catches your eye?
No. What?
Male.
Okay.
And older diagnosis too. So because he wasn't really diagnosed till he was 63 years old. Typically RA is diagnosed around 30s, 40s, but he wasn't diagnosed till he was 63. So that later diagnosis, high titer, he's a male, and those big things put him. We don't know his smoking history based on this, but if he was a smoker, that would put him at higher risk as well too. So that male gender and then older disease diagnosis. So yeah. So that's Louis. Let's keep talking about him. can go on here. So go ahead, Kelsey.
All right. So when you see him, where the PCP sees him in the office on exam, there are some inspiratory crackles. But oxygen is normal at rest, but he desaturates with walking. Chest x-ray looks odd. They comment on some interstitial markings, and then some pulmonary function tests and an HRCT were ordered with some irregularities. So with the pulmonary function tests, with any restrictive pathology that you're going to see with an interstitial lung disease, the FVC is typically decreased. His is decreased to 65. Anything above 80 is considered normal. So once you're below 80, then your PFTs suggest, your pulmonary function tests suggest restriction, and restriction goes along with that ILD diagnosis. But you can't confirm restriction or an ILD restricted pattern on breathing until you get a total lung capacity. The total lung capacity needs to be reduced as well to confirm restriction. And then the diffusion capacity, which we talked about last week, but is significantly reduced, you might say out of proportion to his DLC, out of proportion to the FVC. So the FVC and the DLCO often mimic each other with interstitial lung diseases, and this one is decreased significantly compared to the mildly decreased FVC. And then on HRCT, or high-res CT, which means thin slices. You're looking for 1.25 or 1.5 slices. You see the basal predominant reticulations with honeycombing, consistent with a UIP pattern. We talked about this a little bit last week, but UIP pattern is typically seen with rheumatoid arthritis, ILD, and its predominant pattern is the honeycombing. Reticulation is often associated with it, but it's that honeycomb predominant pattern with that is associated with the UIP pattern. Ground glass opacities are often not seen with this. Mosaic attenuation is often not seen with this. And sometimes you'll see traction bronchiectasis. Interestingly enough, honeycombing, I think radiographically now, is thought to be end-stage traction bronchiectasis. So you could see some traction bronchiectasis, and then honeycombing is the end stage of the fibrotic destruction to the bronchioles on CT. Okay, so what are the ACR/CHEST 2023 guidelines for suspected RA and ILD? Amanda, what does ACR stand for? Is that the Rheumatological Society?
College of Rheumatology.
There we go. Okay. So they put out some guidelines in 2023. They recommend making sure that you're monitoring PFTs and CTs frequently. That's a conditional recommendation, so there's not a ton of strong evidence to support it, but obviously we know that those two go hand in hand, and conditionally meaning that if you do have symptoms, you're going to want to get that testing done. There's a strong recommendation against using steroids in the 2023 guidelines. MMF, mycophenolate, is considered a first-line recommendation on those guidelines and considering an antifibrotic. So based on the next steps, we would think about what type of therapy we'd want to use for Louis.
Yeah. So I think based on all of those things that the primary care knew so much about ordering the HRCT and the pulmonary function test, it kind of goes into our next slide of they were referred to pulmonology, who confirmed the diagnosis of rheumatoid arthritis, ILD, with UIP phenotype. So remember, this patient had been on methotrexate for 4 years. And then adalimumab was started about 2 years ago. And so here we see in the next thing we can talk about like we talked about on the first slide, high titer RFs, older age, male genders, anti-CCP positivity. These are all the high risk, profiles for ILD. So the question is, what baseline and follow-up assessments would you establish for this patient? And I think you kind of hit that, Kelsey, of, but in practice, what do we do? Do you recommend HRCTs every year? Do you recommend PFTs once a year? Kind of how are we monitoring these patients and worsening, I guess?
Definitely baseline PFTs when we first meet the patient. And then, depending on how aggressive their symptoms are progressing, we're seeing them at least every 3 months with repeat PFTs. If the disease process seems to stabilize, maybe you've got them on medication, you might move back to every 6 month PFTs. But that's with stability. And that's also with a patient that you trust that they've got good follow up.
Sure.
It would be really bad luck if this person went a year without getting follow up and then comes back and we realize that the disease progressed and we weren't able to step in. And I'm often doing PFTs if after starting new therapy to see if that therapy worked. And then definitely a high resolution CT at baseline. And then, depending if the PFTs have a big change, then I will get a follow up CT, and also sometimes to assess treatment success or failure, I'll look to get another CT.
Sure. So when you're giving starting new therapy and repeating the PFTs, I know in rheumatology we kind of for our DMARD therapy is a standards around 3 months. Are you doing those PFTs when you're starting new therapy about that, or are you doing it a little earlier?
No, 3 months. At
3 months.
3 months at that top dose. Um, Sometimes it takes a while for a patient to get up to maybe a therapeutic dose, and
Okay.
also, but I will do a virtual check-in, maybe about a month to 6 weeks, to make sure they're tolerating the medication and they're
Sure.
understanding the medication, how to take it. Are they taking it correctly? Are they having some side effects? And do we need to check in on any labs that may need monitoring?
Yeah. Awesome. Sounds good. Good, monitoring. It's always nice to know, okay, well, we've got all this information on how to diagnose this and we've identified, but now, we would change treatment and then what do we do, afterwards? So, yeah, what do you think, Kelsey, about methotrexate? Should we continue this patient on methotrexate?
So, what a good topic for conversation. And glad that we're doing this together, Amanda. So, initially, when I first started in pulmonary, it seemed like methotrexate got such a bad rap. If, like, don't start it, stop it. Your patients who have pre existing interstitial lung disease should not be on it. And then I had actually heard a talk from a rheumatologist, I think from Cleveland Clinic, who came to medical college and talked about how actually there were some studies that said that methotrexate maybe wasn't so bad. And so I looked into some of those preparing for today's talk. Seems like there are some large studies that show that methotrexate isn't associated with progression of interstitial lung disease, and that there's possibly even a protective benefit with methotrexate. Um, so I think this probably just goes to what we always hear about with managing complex diseases, that make sure the patient's at a center of excellence where the provider has experience with the medication and that we're appropriately monitoring it. But my thought is no, it doesn't necessarily need to be stopped.
Yeah. Yeah, I know exactly what studies, you're referring to. I feel like when I started, 15 years ago, it was, definitely be careful of methotrexate, any sort of lung disease, maybe use something different. And then in the recent years, I've seen those exact studies that you were looking at as well too. It's, well, maybe actually there might be some protective.
Mm.
I know our palm guys typically with any sort of lung disease don't encourage stopping methotrexate. They're usually not too concerned about it. I think in this situation, if his rheumatoid was uncontrolled, we're talking about making changes for his disease state because he is, now developing this shortness of breath. It kind of tells me that there's active disease going on, and maybe the methotrexate and the adalimumab is not enough to control that active
Mhm.
disease. It doesn't say in this case how his joints were doing, if he was having tender joints or swollen joints or anything. We're focusing on, ILD, of course. But, in this case, we do know that mycophenolate, azathioprine, tend to do better with ILD. Anyway, and so if he is having active disease, maybe considering a switch to azathioprine or mycophenolate would be kind of beneficial to hit two birds with one stone, so to speak. So I wouldn't necessarily stop it just because of the ILD, but if there's some question about do we need to get better control, we might be able to do that with a different disease modifying agent. And Go
I
ahead.
have like 2 questions for you, Amanda. Methotrexate, when they say like low dose versus high dose, what's considered a low dose and what's like the highest methotrexate dose that you've seen
So
safely?
the highest dose that we use for adults is 25 milligrams once a week. Typically, our therapeutic dose is about 10 to 15 milligrams. Usually, that's thought to have the therapeutic value without increasing the risks of side effects. So that's kind of where we tend to 10 to 20, I would say, is our average. Anything below 10 is considered low dose. I would say 10 to 20 is kind of an average dose. 25 is high dose.
And methotrexate typically does have good effect on the joint symptoms? Okay.
Yeah. Yes. But azathioprine does too. I get some good relief with joint symptoms with azathioprine. So that might be something to, consider as well. If we need that switch to control disease activity and ILD.
Alright, definitely. Okay, let's, you wanna do next slide? We'll talk about.
Absolutely. Yeah. All right, go ahead.
Okay, great. So with Louis, we've been talking with rheumatology and making decisions for disease modifying agents, and then thinking about should we add on an antifibrotic for the interstitial lung disease. Um, and starting a patient on nintedanib is a great idea. And I'm guessing doing some low dose prednisone. Amanda, what do you think about that? Sometimes I use that to kind of decrease inflammation, just to hop us to the next step. Uh,
Correct.
Pull
Correct.
back as
Yeah, according to the ACR for rheumatoid arthritis and ILD, some short-term glucocorticoids can be definitely helpful. Get the disease state under control, especially while we're waiting for some of these medications to kick in. As you said, as we talked about, take 3 to 6 months sometimes, and so sometimes that's enough to kind of keep the inflammation controlled a little better. So.
And the to start nintedanib, typically you need to be able to convince insurance that you've got progression of disease. So at this point, we've probably gotten a second set of pulmonary function tests that show progression with a decrease in the DLCO or the um, FVC, or that we've seen progression on a CT, a high-res CT that shows progression of the disease. So maybe this patient, Louis, he had a CT when he first got started on methotrexate, and then he had that repeat CT when he had worsening symptoms with his PCP. That would be enough to show that we've got progression of disease, and making sure that you're being really specific in your diagnoses code, saying that you've got a progressive pulmonary fibrosis in addition to a connective tissue disease pulmonary fibrosis. There was a 2023 study that used antifibrotics, both nintedanib and pirfenidone for pulmonary for interstitial lung disease, RA-associated interstitial lung disease, and they did show a improved slope of the FVC. So that means that there still was decline, there still was functional decline in the FVC, but just not as drastically as the placebo. The study that I looked at in 2023 that I think got this medication approved for the use was really outstanding. There were 74 people enrolled, 40 got nintedanib, 34 got pirfenidone, and 26 of those patients died.
Oh.
Uh, 4 patients got lung transplants. So I
Oh.
think we'll get to this a little bit in maybe some of the next steps. But making a referral to a transplant early and being aggressive, getting these patients on antifibrotics. These are sick folks who often need oxygen. They're on multiple medications, and we should involve our other colleagues in these patients soon. So I thought that
Sure.
was interesting.
Yeah, absolutely. And then I think as far as the rheumatoid side of it goes, they switched from adalimumab to abatacept for better RA control. And in this case, methotrexate was stopped. So there we go for that.
Mhm. Yeah. And then just general pulmonary care, recommending vaccines yearly. Any type of infection that's going to cause increased inflammation typically seems to offset worsening fibrosis. So making sure that patients are on top of other health things.
For sure. And yeah, those viruses and preventable things that can prevent it from getting worse on top of it would be great. So awesome. And then we talked a little bit about monitoring of the PFTs every 3 to 6 months and
Mhm.
HRCT every 12 months. So.
Yeah, if it's active disease, I hope that I'm seeing that at least every 3 months. And by active disease, I just mean symptoms that aren't controlled. If they continue to have shortness of breath, if the shortness of breath isn't getting better, I'm hoping to see them at least every 3 months. High res CT about every 12 months is a great idea. It seems like I'm doing that a little bit more often. It just ends up being every like 10 to 11 months, just by the way that we're lining up therapy. But yeah.
Their tolerance for starting a tentative if they're doing better on, say, mycophenolate and abatacept, and their PFTs are improving, their HRCT is improving, is there advantage of starting a tentative sooner than later?
Now that nerandomilast, that new antifibrotic, has entered, I would much rather start a patient on something like that. Nintedanib comes with side effects, and if they're doing well and symptomatically improved, it's hard for me to say, "Oh, I want to give you a medication that's slowing things down," when we've already slowed things down, and it's going to give you a bunch of side effects. So more excited to start nerandomilast for some of our patients. But an antifibrotic, if there's any progression, I think should be considered standard therapy.
And then that last question, and maybe this might be more for me, but biologics, other biologics that might be preferred for rheumatoid arthritis. We have adalimumab, our tried and true. We have abatacept. We have lots of new things on the market. One of the cases I know it's not technically approved, tocilizumab for ILD, but we see the benefits with scleroderma and ILD. And we know the benefits of tocilizumab in rheumatoid arthritis with ILD. So I would really consider an IL-6 for this patient, and maybe even before Betacept. Yeah,
Okay.
that's my opinion.
Okay, I love it. I love it. Yeah, I typically just say, "Oh, okay, yeah, yeah. So your RA doctor has got you on this medication. Follow up with them."
Yes, yes, and there are patients, of course, who have tried and failed all these other things, so that Betacept is not a bad option as well. But I think definitely IL-6, that tocilizumab, it's high on my list.
What are
Unless
your
there's
what are side effects that you're looking for and like monitoring with that? How frequently are they getting labs and stuff
with
like that?
tocilizumab,
Mhm.
tocilizumab's every 4 to 6 months. We're doing labs. We're monitoring lipids. We're monitoring CBCs, neutrophils. Let's see. Of course, our tuberculosis screen every year, hepatitis panel at baseline. Those kinds of things. So yeah.
Great. Um, all right, so summarizing Louis' case, we know that RA patients are high risk and need proactive screening, and that screening includes a high-res CT along with DLCO when you're ordering the PFTs. So it's the spirometry and the DLCO, and then at least once you need to order a total lung capacity. The UIP pattern on high-res CT, which is the honeycombing predominant pattern, is associated with a poor prognosis, and antifibrotics can slow that decline. We talked about the different options there. And then, of course, talking with your colleagues with some shared decision making to make sure that we're getting these patients followed up and then also on the right treatment. And it's very common that I'll have a rheumatology colleague say, "Hey, they've got more symptoms, so I think they need to be seen sooner." And I think it goes back and forth.
Mhm.
All right.
All right. So should we get into case number 2? Any other final thoughts on our friend Louis?
Mm-mm.
I don't think so. I think we're ready for our next one.
Yeah.
All right. So this is patient name DA again with the letters. Let's call her Deb because I feel like 6-year-olds Debs are, yeah.
Always a Deb.
Always a Deb. So anyways, she's gonna be a 56-year-old Caucasian woman. And she has had worsening of her dyspnea over the past 6 months, and she is complaining of a very dry cough. She has a history of systemic sclerosis, cutaneous systemic sclerosis. Last week we talked a little bit about the difference between diffuse and localized. And so diffuse is going to be all throughout, core, trunk, all of those kinds of things. And this has been going on for about 2 years. She got this diagnosis about 2 years ago. Seems young. Poor thing.
Mm.
So her clinical features, she has skin thickening proximal to the elbows. She has Raynaud's, those Raynaud's changes at the fingertips, and then a lot of reflux. And her on her ANA panel, she's got a positive SL70. And so what is her the questions are what are her risks what is her risk of developing ILD? And I had to recheck this one because I knew it was high, but I couldn't
Yeah.
I'm not a numbers science thought, numbers I can't spit off, but it's actually 50 to 80% of patients who are diagnosed with diffuse scleroderma will go on to develop ILD, and about 25 to 30% of those patients will develop severe ILD. And so the highest risk is actually in the first 5 years after diagnosis. So for sure, we're screening these people early. Once they get that diagnosis, that positive SCL70, we are, listening to their lungs, asking about shortness of breath, maybe going ahead and referring to pulmonology, making sure that we're already kind of on top
Mhm.
of the ILD side.
Mhm.
Yeah. So if I would say if it's that high, I mean, would a baseline as soon as we were diagnosed, would that be unreasonable to order some PFTs and
Oh,
some?
100%. I think, any new diagnosis of scleroderma of diffuse or cutaneous, I would do baseline, pulmonary function tests and a high-res CT just to know what baseline is.
Yeah, good. Perfect.
Yeah. And so, you had mentioned this last week, Amanda, but these patients are also at high risk to develop pulmonary hypertension because they can have that hardening of the arteries. So worsening shortness of breath over the past 6 months. Yes, I'm definitely thinking interstitial lung disease, but I'm also thinking pulmonary hypertension. And so would probably, along with the pulmonary function tests and a high-res CT, be also getting an echo right around the same time, just to make sure that that's not developing or worsening. Um, so this CT has honeycombing with that UIP pattern, but just as common, if I can remember those slides correctly, to get the NSIP pattern, which is um, uh, also very common in the systemic sclerosis scleroderma patient. Those patients are going to have more of the ground glass opacities and reticulation, possibly with some peripheral sparing, versus the UIP pattern, which is more honeycombing. But you definitely can see both. So seeing one or the other wouldn't be surprising. Definitely would want to refer this patient to transplant and initiate treatment right away. These patients are tricky, for transplant, like you mentioned, Amanda, because they have the acid reflux, they have the GERD, and they often have that esophageal dysmotility. So if they have a lot of aspiration, that makes them a difficult transplant candidate or just a more challenging transplant candidate. And also, if a patient has shortness of breath and they have scleroderma, I'm also thinking about, are they aspirating, and is that what's causing the new shortness of breath? But this one clearly has interstitial lung disease with the UIP pattern. So getting them to see transplant, like we talked about last week, most patients who get a diagnosis of interstitial lung disease, we're starting that transplant conversation early if they're going to be a candidate, just to meet the team, and then getting them on a anti-inflammatory, a steroid-sparing anti-inflammatory medication, because like we talked about last week, we want to try and avoid steroids, long doses of steroids, and high doses of steroids, because we want to protect these patients from a possible renal crisis, which they are at risk for. So we can go to the next slide. So with this one, mycophenolate is initiated. This is typically one that I'm okay starting on the pulmonary side myself, but definitely communicating with the rheumatologist or saying, hey, I think we just should start mycophenolate. Are you okay with that? Do you want to be the one initiating this therapy and then monitoring, referring to transplant, and then, of course, monitoring for other health maintenance needs like vaccines, introducing to palliative care. What role do non-pharmacological interventions play here? This can be really big. Thinking about oxygen. Oxygen is a natural pulmonary vasodilator, so making sure that they don't develop pulmonary hypertension related to hypoxia or decreasing that risk. Oxygen monitoring is going to be a big one. Monitoring and adjusting therapy based on uh, repeat pulmonary function tests and then also repeat HRCTs. Another non-pharmacological intervention, talking about aspiration, making sure they know to keep the head of the bed up at night, small, frequent meals, not getting too full, things like that to reduce their chance of aspiration and keeping them to be a good lung transplant candidate down the road. What did I want to talk about here? These patients are also good candidates if they've got progressive pulmonary fibrosis. They are good candidates for antifibrotics. The Census trial recently approved nintedanib as an antifibrotic therapy for our scleroderma patients. And that started earlier with the INBUILD trial where they were looking at all types of progressive pulmonary fibrosis, and 25% of those patients had a connective tissue disease. So these patients are definitely candidates for antifibrotics. And like we've talked about, we've got a few different therapies now, nintedanib and then nerandomilast. I don't think pirfenidone has the antifibrotic indication for this disease process yet. I just talked a lot.
No, you did. I love it. I love it. Yeah. So, I think in summary, for this case is just recognizing the risk of ILD and that it's really high in patients with systemic sclerosis. So, I think as rheumatologists, anytime we make that diagnosis, getting our palm colleagues involved sooner than later, and really trying to stay on top of it so that hopefully we can catch it and slow it early. And so recognizing the progressive fibrosing ILD and kind of initiating that immunomodulator therapy and then the timing of the antifibrotic therapy and then that timely referral. I know you mentioned it last week, Kelsey. I mentioned it again. And I think, referring over to transplant, sooner than later and getting that in place is always a good thing. So what else
And
do
then
you got?
Well, Amanda, are there anything else that you're using for immune modulator therapy besides the mycophenolate? I feel like I use that one a lot.
Yeah, so mycophenolate, I'm trying to think. I've one patient with the scleroderma, and ILD. She's got pretty aggressive. So I have started tocilizumab. She's doing great on
Okay.
that. So that's definitely a good one. Avoiding those steroids with the sclerosis, like you said, with the renal crisis, we don't use any of those. So yeah, so those are my go-tos really, is the mycophenolate and the tocilizumab in a scleroderma patient.
Yeah, yeah. I mean, this is such a tricky disease. These patients, often because they develop pulmonary hypertension along with interstitial lung disease, they're seeing two pulmonologists in our office, one that focuses on the interstitial lung disease and one that focuses on pulmonary hypertension. They're also seeing their rheumatologist. It seems like more and more I'm seeing these patients also develop like a diastolic dysfunction with heart failure, like a left and right-sided heart failure, so they're seeing a cardiologist. So like you said, these are sick patients. They need a lot of co-management with different colleagues, and then just being able to communicate across those lines to make sure that we're getting the best care for these folks.
Yeah, and I would even add a nephrologist in there too because of the risk of renal sclerosis as well too. So that's a lot. I mean, that's a lot of visits.
Yeah, that's a lot. Yeah.
I always think of my poor lady that I have, and she's a little older patient, and she just kind of came on all pretty suddenly for her, and it was a bit overwhelming and depressing, and she wanted to live to see her grandkids get married and all this, and so it's a lot. It can be a lot for them, and so that nice encouraging and when we are able to connect and have confidence in our connections and our ability as a team to really approach these patients, then they become more confident in their disease. And you're right, they're very sick, so they do need a lot of support. So
Mhm. Yeah, it's definitely and taking that coordination of care off of them and onto our plate because otherwise it's just too much for them.
Correct, yeah, and knowing who to refer to and saying, "Hey, I have this great colleague, I want you to go see them. They're gonna know about your, lung disease and all that kind of stuff, and they can answer this question or they'll answer that question," and so, really that team approach is huge for these guys, so, yeah, awesome.
Definitely. Awesome. I
Alright,
feel
go
like we
ahead.
talked a lot about this.
I think so. I think so. I one of the things I think I thought about last week for my room colleagues is the importance of really listening to all the lung fields, right? Not just a quick lung exam, but really listening to all the lung fields. And then also asking, have you had shortness of breath? Have you had a dry cough? I think sometimes we're talking about so many things and they're worried about their fatigue or they're worried about their joint pain that maybe
Mhm.
they don't even think about like, oh yeah, I guess I have been short of breath. So
Mhm.
I think one of the things that I kind of took away from, doing this is we really need to be asking because this is a high prevalence in rheumatic disease. And
Mhm.
need to, be proactive about it instead of, oh, you've had it for a year and now you've had the damage that's done.
I think also exactly on the same line, Amanda, that I focus so much on the shortness of breath and the cough that I often don't ask about the joints or the fatigue. But if I do ask those questions and if they are saying yes to it, well, then that's only shaping my suspicion even stronger and I'm acting more aggressively. Shortness of breath can be a symptom that can be caused by so many things. But if you're telling me you're short of breath, you're coughing, your joints are hurting, and you're fatigued, well, this is active disease that needs, quick management as opposed to, "Oh, let me have you come back in 3 months and see if the PFDs are gonna continue to decline." I know they're gonna continue to decline because they've got active disease. So, to act quickly when you're taking the whole patient into consideration, I think is a helpful takeaway, for sure.
Yeah. Yeah. And then I think we kind of hit that how has this shaped our ILD suspicion and management framework. I think, but on both ends, kind of watching out for those other things going on. Um, and then what part of the diagnostic or treatment timeline do you feel most confident in or least confident in? I I think this is probably more for the audience than anybody, but, it's a good thing, and if you do have questions, people who are watching this later on, if you have
Mhm,
questions, reach out, connect with your colleagues. If I've learned so much from Kelsey, just, talking with you and doing the presentation with you, and so it's great, like, "Hey, Kelsey, would you we
mhm,
just had PFTs 3 months ago. Should I grab them again? What should I do?"
mhm.
Use your resources.
Yeah, yeah, use your resources, and I think if anything, this talk has given everybody the license to, like, order those serologies or order that high-res CT. No one's gonna question you when you're trying to do the best for a patient, like, "Why did you do that? That was a waste of resources," or something like that. No, if you're making a decision for your patient, order the tests so that we're not delaying these diagnoses, then sending them to the consulting service that can help the patient too, but
I've had a couple patients who, come back and they say, "I saw the pulmonary," not in Freighter, not in Freighter, in our neck of the world, but, yeah, who've come back and said, "Well, I saw pulmonology," and they, got said to come back in 6 months. I'm like, "No, no, 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 we're gonna order. You got,
Mhm,
RA, you got this.
mhm,
I'm putting
mhm.
an order, you're going for that."
Yeah, yeah. I think
Um
yeah, exactly. Have the confidence to do the ordering if you're advocating for your patient.
Yeah, absolutely. And as far as palm goes, run those panels, and if you see something suspicious, send them our way. So we're happy to take care of them on that end. So this has been really fun, Kelsey. Thank you
Yeah,
so
this is so fun. I'm so happy to have your cell phone number and your email address and all
much.
those things.
Oh, I love it. I love it. All right. Well, thank you all for joining us tonight, and we will talk to you soon. Later.
Yeah, thank you so much. Take care.
Bye.
Bye.